Hey everybody, today we're going to start on the B vitamins. So specifically we'll be looking at thiamine today. So just to kind of clarify, the water-soluble vitamins are basically vitamin C. So obviously we did that already. And then the rest of the water-soluble vitamins are these 8 B vitamins that we're going to be going over the next few weeks. So I just to kind of put this out there like right away, the B vitamins are it's hard to remember what each of them do. They're mainly involved kind of like in glycolysis, the Krebs cycle, that type of thing. They all have these like intricate little jobs in helping with metabolism. So it is really difficult to remember specifically like what thiamine does in the Krebs cycle or what riboflavin does. So you'll probably remember it for the exam, but in all honesty, a year from now or whenever, I think it's going to be really hard for you to remember what these specific things do. So I just wanted to clarify and say this is something I'm going to go over basically every B vitamin lecture. Just remember as a general thing that the B vitamins are involved in energy release. You could also say like energy metabolism. So what I mean by that is like helping the Krebs cycle kind of chug along, glycolysis, etc. And then it's also involved in formation of blood components, so hematopoiesis. And that more specifically relates to folate and B12. So we won't be talking about this component, but I'm going to kind of go over this multiple times just to kind of keep in mind that these are the two major things that the B vitamins do, because it's really easy to kind of get lost in all the details with all these lectures. So to kind of back it up a bit, just to remind you that thiamine was basically the first vitamin ever discovered. So it's a disease. They basically discovered it through this disease of polished rice, which we kind of discussed briefly in the first lecture. And if you remember that basically what was happening in Southeast Asia in the late 1800s, it became really common to remove that outer husk of rice. So this confuses people. So this is rice that has no husk on it. So if you're kind of unfamiliar with what rice plus a husk looks like, you can just, Google image that really quickly to kind of remind yourself of what that looks like. But this is polished rice. So kind of what we're used to buying at stores, for the most part, is rice with the husk removed. And so that became really common practice, 100, 150 years ago or so. And I'm not sure why. Potentially, it was maybe some type of like socioeconomic thing that, it's kind of like when they started introducing white bread. It's all tied into kind of like looking fancier. This is like what the rich people do or something like that, I assume. But it just became kind of common practice for certain groups to start removing that husk of bread, the husk from the rice. Unfortunately, that husk, so the thing that kind of envelops that rice kernel, has all like most of the nutrients in it. So pretty much most of the B vitamins were in that husk. So when you take those off, yeah, you're basically losing like a lot of the nutrition from that food. And so when they started doing this practice of removing the outer husk of rice, people in these areas that were doing that started developing neurological disorders. So specifically, it's now called beriberi, but that means that, they would start getting these like kind of tingly fingers and toes, and eventually over months or years that could lead to like full-blown paralysis. And then this led a scientist called Dr. Eichmann to try to figure out what was going on with this population. So, why all of a sudden were they developing these neurological symptoms? And he was able to kind of track it back to the food source. So he noticed that this started developing when people started removing or refining the rice, basically. And then he took the husk, and he was the one that basically found thiamine, so isolated thiamine from the husk. And yeah, that's basically how the first vitamin was ever found. So then it kind of all goes back to what we previously discussed kind of briefly, but most vitamins are usually found because they notice that a population group develops a certain disease state. then, if they can, they link it back to a food. And usually it's because they started changing, whatever they were eating or maybe how they were processing it. And then they kind of see what the change was, or they isolate basically the vitamin or the nutrient from the food in that way. But it does usually start with disease state, figure out the food or the absence of what food is causing it, and then isolate the vitamin from that food source. So this is what thiamine looks like. And again, before kind of launching into this, for the sake of exams, you do not need to draw things out. I just don't think that that's very useful to you as dietitians. If you want to go into biochemistry of vitamins and minerals later, sure, definitely you should know what it looks like then. But moving forward, I don't think you'll ever really need to know what the structure of thiamine looks like. But if you're interested, just to note that, obviously they're organic compounds, and they're fairly complex. They're small, but this is far more complex than what we saw for vitamin C. So it involves a pyrimidine ring, and then it's attached by a methylene bridge to this thiazole moiety. So that's pretty much what it looks like. But again, this is kind of just for you to see what it looks like. You do not need to memorize or know these two specific components. Food sources of thiamine. Basically, how do I say this just to make it easier straight up front? Most B vitamins, you're going to get it from meats and grains. So usually like fortified or enriched grains. But meats and grains are the main sources. So it is really hard to remember so many different things for the B vitamins because there's so many of them. Again, we're going to go over 8 of them. And, it's just hard to remember exactly kind of who does what type of thing. So throughout this whole process, I'll definitely be giving you kind of like in general, these are the food sources. In general, this is the absorption, etc. So in terms of food sources here, first things first, I guess, you want to put on the DRIs. So just to label that, for women, it's 1.1 milligrams per day. And for men, it's 1.2 milligrams per day. So 1.1 and 1.2. And then once you have that information, you can kind of compare how much you're getting from what. So for meat, pork has a lot of thiamine. So just a typical kind of serving of pork will have everything you need for the day for thiamine. In general, I always highlight Cheerios in this B vitamin section just as like a general cereal that people eat. But I don't know, just a typical cereal, I guess. And then usually what you're going to find in a lot of these kind of fortified and enriched cereals, so most of the cereals you see in the cereal aisle, you'll notice that B vitamins are usually fortified up to about 25% to 50% of somebody's needs. So in the sake of thiamine, you're usually getting about 50% of your thiamine needs for every serving of cereal. So, if you have like 2 servings of cereal, you're pretty much fine on thiamine. And you'll notice that there's tons of B vitamins. They probably have like most of the B vitamins in these cereals. Rice, so this is cooked rice. 1 cup of that is 0.44. This is, unfortunately, right now, since you lose a lot of the thiamine, remember with the husk, this is the enriched form of that. So they do add all those B vitamins back now. So we are not, we eat a lot of rice. It's a pretty staple food, I'd say, for people that eat carbs. And yeah, they've kind of added that all back. So you're getting almost 50% of it from, a typical serving of rice. You also get it from like bagels, beans, that type of thing. But the main thing you really get it from is enriched fortified grains, some whole grains as well, and meat. And then it occurred to me that some of you might not be either familiar with enriched versus fortified, or maybe you took this in a class and it was a really long time ago. So just to kind of reacquaint you with these definitions. An enriched food is something where the vitamins or minerals have been added back to the food to replace what was lost during the refining process. So say you're taking wheat or whatever and you do all these things to it to basically make it become Cheerios. you lose a lot of the vitamins during that process. So they're just adding it back to the level that was already in the food. Whereas fortifying is when you're basically adding vitamins or minerals to the food in addition to the levels that were found before. So, if wheat had whatever certain amount of thiamine, uh, let's just say 1 milligram per whatever. Um, and then, so enrichment would be you unfortunately lose a lot of that thiamine, and then you would basically just add back that 1 milligram afterwards. Whereas fortifying, you would add back 1 milligram and more. So let's say 1.5. So you're kind of giving like a bit of bonus vitamins and minerals in fortified foods. So more than that, what was there in the original food. Supplements that I've seen are thiamine sold as thiamine hydrochloride and also thiamine mononitrate. But I do have to say, before you kind of go and, I don't know, start looking at Target or whatever, the main thing that you're going to see for B vitamins is that they're sold as a complex. It's very, very unlikely that you would ever take just one B vitamin. The thing is, the B vitamins are so interconnected in terms of metabolism, and they're kind of all needed. Well, it's kind of early on to say this, but you'll notice there's so many things where they kind of depend on each other for activation or just what their actual jobs are in metabolism, that if you become deficient in one B vitamin, you tend to become deficient in all the rest as well. So it's more important to take a B complex than kind of isolate what the actual B vitamin is. Also because water soluble vitamins are a lot less toxic. We kind of just like pee them out right away if you get too much. So for the most part, that's what's done. In terms of what cooking does to thiamine, very similar to what we saw with vitamin C. So you will see that the vitamin itself degrades or decomposes at really high cooking temperatures, so 190 Celsius. And again, you really need to be doing like pressure cooking, like deep frying or kind of like barbecue grilling to see the actual vitamin like get destroyed. But the main way that we really do lose the B vitamins is when you're basically like boiling something. So if you have like beans or something that you're boiling, you're going to lose most of that thiamine into the cooking water. So again, the thiamine itself isn't destroyed with boiling, but it all seeps out of the food and enters the cooking water. So you want to recoup that cooking water in what you're making to get that thiamine back. Now looking at digestion, in general, we get thiamine from plant sources and the meat sources, as we mentioned before. So when we get it from a plant source, so say like a grain, we actually get it as free thiamine. So there's nothing attached to it and there's no digestion required. Whereas when we get it from a meat source, so pork, for instance, when the thiamine in food has two phosphates attached to it. So this is also called thiamine diphosphate. And basically, the body can't take it in with those two phosphates attached to it. It needs to cut it down to its most basic format for it to actually enter the enterocyte. So then what happens at the level of the intestine is you have this phosphatase enzyme that kind of comes along and literally just cuts off these phosphate groups and then renders free thiamine. And then that way it's kind of in the right format for the enterocyte to take it into the body. So a couple kind of trickier things with thiamine and digestion. There are these things called anti-thiamine factors. So there's two types. One, there's something called a thiaminase. And this is primarily found in raw fish. So if you do consume a lot of raw fish, this is something that would catalyze the cleavage of thiamine or basically destroy it. The only thing you can do, so again, if you have rice that has thiamine in it, and then you have, some type of raw fish with that, basically, as you're like eating this, those thiaminases in the raw fish will destroy the thiamine, kind of like during that process of digestion. However, you can avoid that if the fish is cooked. So when you cook that fish, it renders that the thiaminase is inactive, and then it won't go on to destroy the thiamine. So that's one thing. So I wouldn't, you don't have to avoid raw fish altogether, but if you are consuming primarily raw fish, and then you start developing some of these like B vitamin deficiency symptoms, which we're going to talk about, then yeah, maybe look into that. But that's just one thing to consider. The other food group or the other compound is polyhydroxyphenols. So, like tannic acid, caffeic acid, these are found in like coffee, tea, blueberries, red cabbage. These are things that will unfortunately uh, just destroy thiamine by an oxidative process. Unfortunately, kind of cooking the cabbage or whatever doesn't render these things inactive. So if you're consuming, thiamine at the same time, some type of grain, I guess, along with one of these food components, most of the thiamine will be destroyed. Consuming vitamin C at the same time can help protect it a little bit, but it doesn't fully protect it. So this is also one of the reasons that a lot of food cultures, well, I noticed, so I went to France a few years ago and I ordered breakfast and yeah, I just ordered breakfast and then I also wanted some coffee with it. And the waiter looked at me like I was completely insane. He's like, "Wait, you want coffee with your breakfast?" Well, no, we usually serve that like a good half an hour after people are done eating. So I was surprised. But yeah, there's a lot of cultures where they kind of, I'm not sure how they know it, but they just know to wait to basically space out the coffee from the food ingested so that the coffee doesn't get kind of involved or mess up the absorption of these nutrients. I'm not sure if they thought that far about it, but I was really impressed that, yeah, certain cultures do not allow coffee at the same time as food, and maybe it's because of this reason. So now looking at specifically absorption, so how does it get into the enterocyte? So I know we only went over this once, but if you remember it with vitamin C, you'll notice that it's pretty much the same for all the vitamin C and most of the B vitamins we're going to look at. So at a high intake, remember, the body does not want to expend any resources or energy because there's so much of this vitamin coming in already. So if you have a lot coming in, the body will simply use just passive diffusion to bring it in. Whereas if you have kind of a low to normal intake, you're going to use a sodium dependent transporter or some type of resource, some type of energy to bring it in, because the body senses, oh well, we're only getting kind of like minimal quantities of this. Let's do our best to like get as much as we can into the body. And then so that's coming into the enterocyte. On the way out into the blood, so on the basolateral side of the enterocyte, it actually, thiamine leaves by, and some of the other B vitamins as well, leave by this hydrogen antiport carrier. So remember from your chemistry classes that an antiport carrier is basically when one thing goes out in exchange for something else coming in. So in this case, it's one thiamine going out for one hydrogen coming in. And then basolateral, this is an interesting thing that is pretty important to keep in mind. So basolateral absorption, so this whole process can be inhibited by alcohol consumption. So you may know that people that are alcoholics, kind of severe alcoholics, tend to develop B vitamin deficiencies. And this is one of the reasons. So thiamine and some of the other B vitamins can enter the enterocyte, but they can't get out into the bloodstream because basically alcohol is blocking this mechanism from allowing thiamine to kind of get out into the rest of the body. There's other reasons too. Alcoholics also may be replacing, instead of eating food, they may be just having alcohol, so there may be a replacement there. But definitely alcohol interferes with B vitamin absorption as well. Thiamine in the blood is transported as thiamine monophosphate. It can also be incorporated into red blood cells, so most of thiamine is transported in this way. Bound to albumin, and it also travels in a free form. It's stored all over the body, but there's a really high percentage in muscles, skeletal muscles. In the brain, a little less so. Liver, kidney, and heart also have certain amount. So we have about 30 milligrams total as a body store. Once thiamin's absorbed, most of it's taken up by the liver. So about 80% will travel then to the liver. And remember, we're dealing with the free thiamin form because from plants it was in its free form already. And then from animal products, the food source, it did have those two phosphates attached, but remember we cut those off, and then which rendered that free thiamin. So it goes to the liver, and then it becomes two forms of thiamin. One, thiamin diphosphate, so not surprising, you add two phosphates here, or thiamin triphosphate, so adding three phosphates. So this is something that I'm going to go over in this lecture, and then my TA is actually teaching the next lecture for riboflavin, but I do have these slides in there again. This is something that confuses people, but it's a really important concept when it comes to the B vitamins. So the B vitamins don't, how do I say this? So thiamin itself can't do its function in the body unless it's in a coenzyme form. And this is pretty much the case for every single B vitamin. Vitamin C, it does not apply to vitamin C. Vitamin C is kind of its own thing. But pretty much all the B vitamins need to be in a coenzyme form to do its job. So what is a coenzyme? You may remember this from biochem. It's a substance that activates an enzyme, and then the enzyme is basically not active till the coenzyme is attached. So just to kind of give you a pictorial representation of this. So here's thiamin, just straight up thiamin, free thiamin that we got from food sources after phosphates are cut off. We make thiamin then into its coenzyme form. The coenzyme form happens to be thiamin diphosphate or thiamin triphosphate. So for the sake of thiamin, all we're doing to make it into this kind of active form is adding two phosphates or three phosphates to it. And then once those phosphates are added to thiamin, then it's in its kind of like ready to go active coenzyme form. And it has to be in this form in order for it to bind an enzyme and render that enzyme active. So once again, super important concept, so I'm going to go over it one more time. Once we absorb thiamin into the body or any other B vitamin, it's usually we've kind of cut it down to its most basic form. So you'll notice that as a pattern too. The body will usually only take a nutrient in its most basic form to absorb it. Then we kind of have to build it back up into a coenzyme. So in the sake of thiamin, that's adding either two phosphates or three phosphates. Once those phosphates are attached, it's the active form of thiamin, also called the coenzyme form. And then it goes on to do its function in the body, which is basically attaching to an enzyme and then activating that enzyme. And this is what pretty much all B vitamins do. They come into the body as a basic B vitamin. The body does something to them, usually adds a phosphate group or some other kind of small group to it. It then makes it active, and then it binds to certain enzymes, and we'll go over that in a second. And then, that's basically what it does. But B vitamins have to be in their coenzyme form before they can do their job. That's the main thing I want you to take from this. So I already mentioned it, but to go into a bit more detail, the two coenzyme forms for thiamin are thiamin diphosphate. Pretty simple, you're just adding two phosphates there. And that's basically made by phosphorylation from thiamin to TDP, thiamin diphosphate, using this enzyme, thiamine pyrophosphokinase. And then ATP is also used in this process. But very basically, you're just taking thiamin, adding two phosphate groups. So that's the first coenzyme form for thiamin, thiamin diphosphate, adding two phosphates. The second coenzyme form for thiamin is thiamin triphosphate, where you're adding three phosphate groups instead. So that's basically done. So you do start with TDP, so the one with two phosphates attached, and then you simply just add a third, And this is done by the enzyme ATP phosphoryltransferase. So yeah, you're basically just using ATP and to make TTP, thiamine triphosphate. And then all of these different ones can be pretty easily converted, or interconverted, I should say. So here's thiamine triphosphate with the 3-phosphate group. So these little orange circles are the phosphate groups. And then the body can easily kind of remove phosphates and kind of put it back to its like free form, or it can build it back up depending on what it needs. So there's 3 major roles of thiamine. Energy transformation is one of the big ones. So that's what I was talking about with like in that initial slide where I said mainly B vitamins are involved in energy metabolism or energy release, energy transformation, however you want to show that. And that's basically what its role is in the Krebs cycle, or glycolysis as well. It also helps in the synthesis of pentoses and NADPH. And then it's also involved in membrane and nerve conduction. So first of all, what's some of the things that it does in the old Krebs cycle or TCA cycle? The very first thing that it helps out with is the conversion of pyruvate to acetyl-CoA. So in this very important kind of intermediate step between glycolysis and the Krebs cycle. And then the next thing that it helps out with in terms of energy metabolism or energy release is the conversion of alpha-ketoglutarate to succinyl-CoA. So this step over here. So a bit more detail about both of those things. If you remember, the conversion of pyruvate to acetyl-CoA involves the decarboxylation. So that's when you're removing one of those COOH groups of pyruvate. And it does require this like multi-enzyme complex. This is actually what it looks like. It's pretty cool that they're able to actually kind of, just figure out what these large enzyme complexes actually look like now. So it uses pyruvate dehydrogenase, which is bound to the mitochondrial membrane. So specifically, kind of converting pyruvate to acetyl-CoA is this multi-step process. But thiamine is used in the form of a coenzyme, so specifically in its TDP, thiamine diphosphate form, kind of in this first step of this whole process. So it helps remove that carboxyl group at the beginning here. And then the next thing that it does, so completely unrelated to that other one, so this is kind of near the bottom of the Krebs cycle, if you kind of look at it really as that circle, it helps in the conversion of alpha-ketoglutarate to succinyl-CoA. So again, that's also another thing that involves like a decarboxylation step. So you're decarboxylating alpha-ketoglutarate, and this time it's the enzyme that's being used is keto acid dehydrogenase. So thiamine comes in again in its coenzyme form. So as thiamine diphosphate kind of latches on to this enzyme and helps decarboxylate alpha-ketoglutarate so it can then become succinyl-CoA. So those are kind of the 2 things that it does. If you remember, you might remember alpha-ketoglutarate and then also the keto acid dehydrogenase complex because of what you probably learned in Dr. Song's class. If you remember, this is the enzyme that's involved with the decarboxylation also of the branch chain amino acids, so isoleucine, leucine, and valine. And then those are the ones, it's also involved in that maple syrup urine disease. So I know it's probably a review for most of you, but just to kind of link that back to what you learned before, remember maple syrup urine disease, or MSUD, is a genetic absence of the keto acid dehydrogenase complex. So basically people are missing that enzyme. And then because of that, those branch chain amino acids accumulate in the urine and in the blood. And then basically people are put on like special diets where they're limiting protein intake. And it does affect, still it affects about 1 in 180,000 infants. And then the things that it's kind of noticed very quickly in infants, from what I understand, if you're working in like a pediatric unit, after the infant's born, the urine smells a lot like maple syrup. And I guess that's where it got its name from. and it can basically turn into like or evolve into like brain abnormalities, seizures, lethargy, dermatitis. All these things are kind of noticed. But yeah, if left unchecked, it can have pretty massive implications for the nervous system. So it's usually treated very quickly. So then to kind of just go over in general what these reactions are essential for. And again, I know a lot of this is probably a review from Dr. Song's class. But just remember the main thing that that whole Krebs cycle is for is ATP generation. So we're mainly making these NADHs, and then that is basically passed on to the electron chain, the electron transport chain, to generate ATP. And then in terms of, so that's that whole alpha ketoglutarate to succinyl CoA. The main point of it is to generate energy in the form of ATP. Whereas with acetyl CoA, that's not used in the electron transport chain, as I'm sure you remember. That's usually used as kind of a basic building block to make fats, so fatty acids and cholesterol. So that's more of this is more just sheer energy metabolism, and then this is kind of a more of a synthesis side of it. So if thiamin's not available to act as a coenzyme in these reactions, two things would occur. One, you'd get kind of increased plasma concentrations of alpha ketoglutarate. So these are certain things that they'll measure to try to isolate what's going on. But the other thing that you'll notice is that since this pathway can't continue, there's increased levels of pyruvate in the blood. This can lead to lactate accumulation and then acidosis as well, so it can be quite dangerous. So those were the two first things that we talked that I listed as a function. And then the third is the hexomonophosphate shunt, which I realize Dr. Song refers to it as the PPP, so the pentose phosphate pathway. So you can kind of cross that out and use whatever word works for you. But it is hexomonophosphate shunt is synonymous to the PPP. And remember, that's kind of this part up here of glycolysis, kind of like a little sidestep there. And the whole point of that pathway, the PPP, is to make NADPHs and pentoses. And those two things are pretty important because basically it transforms sugars of varying chain lengths to either pentoses, and those pentoses are used to make nucleic acids. And then NADPH, again, that can be used to make fatty acids. So that's pretty much what it does. And I know, again, you just took Dr. Song's class, so hopefully that's all kind of fresh in your mind. The enzyme involved in this, in other words, to like convert these sugars, so ribose or xylulose, into pentoses or NADPH, is transchelatase. And then, of course, thiamine has to be in its coenzyme form. So in this, for the sake of this, it's TDP again, to kind of latch on to that transchelatase to help in this reaction. All right, so the first two, those are all done now. And then the last one is kind of a newer one that they have discovered. So when we get into the deficiency slides for the B vitamins, you'll notice that kind of problems with like nerve conduction are like a really common thing you'll see. So kind of having like numbness of fingers, toes, and the limbs is something that happens when you have a B vitamin deficiency, and it can lead to like full-blown paralysis as well. And so they never really understood like why is it that if you have low intakes of B vitamins that all of a sudden people kind of are slowly becoming paralyzed. So more recently they discovered that thiamine, and there's some other ones too that we'll talk about, do have some type of role in nerve conduction. Before I mention what the specific role is, I just want to go over kind of the process of nerve conduction really quickly, and then I'll show you exactly what thiamine's doing. So just remember from your physiology classes that a nerve impulse basically starts with a stimulus. Then you have that whole action potential that travels down the nerve where you have I always say Na in my head, but sodium rushing into the neuron, and then potassium kind of coming out. That's that whole action potential. Once the action potential kind of reaches the end of the neuron, that kind of stimulates a neurotransmitter to be released at the synapse here. That neurotransmitter then binds onto the next neuron, and then that impulse is basically travels down the next one, which is again that action potential till it gets to again the end of the other nerve. So what is thiamine doing in this? They've discovered that thiamine does have a role in kind of two major things. One, when sodium rushes into the neuron, it's involved with that. And then also when the neurotransmitter binds the receptor. So it's kind of complicated. I don't want to go into like an insane amount of detail here. You can, feel free to read on PubMed if you're really into like neuroscience, but honestly, a lot of it is pretty complicated. But just to kind of tell you very basically, they found out that thiamine, as TTP, is involved in the regulation of those sodium channels. Whereas, sorry, my dog's barking. I don't know if you could hear that. It's also involved in the regulation of neurotransmitters, so specifically acetylcholine receptors. So yeah, basically, it's really cool. They found out that B vitamins they don't just help with energy release. They actually can have certain roles in nerve conduction as well, which makes sense because, one of the main deficiency disorders is, basically numbness and paralysis. So the RDA, as I mentioned before, for women is 1.1 milligrams per day, and for men it's 1.2. A lot of this information comes from, again, those balance studies where they basically see, depending on how much somebody's taking in, how much is the body letting go of. That's primarily how they assess this. And again, I know I mentioned it before, but if you're interested in finding out exactly how they come up with these numbers, all of those studies are in those DRI books, which are online. So they basically have like all the studies that led up to like how they came up with these specific numbers. It's pretty nitty gritty. I admit I haven't read all of them. I've looked up certain things, but it's like, these are like 500-page books basically, and they're all different ones for like different sets of vitamins and minerals, etc. And then the reason that men need a little bit more than women is just because of slightly higher energy needs because of more muscle mass and higher body size. So the deficiency of thiamine is, as we mentioned it before, it's called beriberi. Berry means weakness, so I guess that's how it was named. And there are 3 different types of beriberi, but most individuals are going to show a kind of cluster of symptoms where at first they're going to have kind of lower appetite, some weight loss. The second sign can be some cardiovascular symptoms such as rapid heart rate. And then eventually, if it's not treated, you're not going to see those neurological symptoms for a while. So those tend to happen like after a good year or so of having this deficiency. So the first type of beriberi is called dry beriberi. This affects older adults, and it usually occurs when people are having high amounts of carbohydrate intake, but low intake of thiamine. So I guess they're not eating, enriched grains. It's just consuming grains where I guess, maybe they've been refined and then those B vitamins have not been added back. The symptoms of dry beriberi are muscle weakness and wasting, a lot of different nerve problems such as sensory, motor nerve conduction problems, and then the kind of numbness or peripheral neuropathy of kind of like fingers, toes, that type of thing. So those are the things that are noticed. So again, it affects older adults, and a lot of dry beriberi is mainly like nervous condition problems. Wet beriberi, on the other hand, also affects older adults. It tends to result from when people are just having kind of low intakes of thiamine. So it isn't coupled basically with that high intake of carbohydrate as well. And then this one, I guess, I don't know why they called it wet beriberi, but maybe because it involves all these things with the cardiovascular system and blood is wet or something. I honestly don't know. But that's kind of how I remember it. So wet beriberi, again, older adults, just low thiamine intake. And you're really seeing a lot of CVD kind of things here. So cardiomegaly, enlarged heart, tachycardia, remember that's rapid heart rate. And then right side heart failure can eventually occur as well. So dry beriberi, nervous system, wet beriberi, CVD symptoms. And then acute beriberi, kind of different from the other two in that it affects infants, so usually newborns. It results when infants are kind of malnourished, but specifically not getting enough thiamine for some reason. Potentially it's just low in breast milk, or maybe they're being fed cow's milk or something like that. And then the symptoms are fairly immediate. Lactic acidosis develops, anorexia, vomiting, and eventually altered heart rate and cardiomegaly. So it needs to be treated, obviously, very quickly in newborns. In terms of deficiency, a lot of people, well, it was definitely a lot more prominent to have these beriberi kind of conditions back in like the 30s and 40s in the US. And because of this, they decided to do this kind of public health approach where they started enriching grains and flour specifically in the 1940s. And you'll notice right after they started doing this, so even by 1946 here, I don't know the exact year that they started, but I'm assuming it's probably like 41 or something, that it basically just plummeted. So the rates of people getting beriberi went way down once they started enriching grains. Other deficiency disorders that are more particular to people with alcoholism, or even in people that are AIDS patients that are not kind of actively being treated, is Wernicke's encephalopathy. So that's something that you might see it as a dietitian in clinics or hospitals. It is somewhat common in the United States. And it's usually, I think you'll probably see it more commonly in like alcoholics, but usually what you're going to see is a bunch of different kind of, mainly like things with the eye. So I always mess up this word, but ophthalmoplegia. Okay, I said it okay. Ophthalmoplegia is paralysis of the ocular muscles, and then that's accompanied with nystagmus, which is this kind of like constant involuntary eye movement. It's almost like the eyeball is like, or the eye itself is like shaky. So that's one thing that you may notice. And then ataxia, impaired muscle coordination. So just for the rest of the body, there's some other nervous system problems there as well. But interestingly, a few years ago when I was teaching this, somebody went on, the next year to do their rotations, and they actually pointed out nystagmus in somebody in their rotation in the clinic they were working at. And so they kind of picked up on it because they remembered this lecture actually, and then they told the dietitian, the attending dietitian, and the doctor. And it was diagnosed that they actually had a B vitamin deficiency. So in general, nobody really knows why these exact deficiency symptoms occur. Like, why does all that stuff happen with your heart? And like in general, the nervous system stuff, sure, maybe it's tied into thiamin's role in those basically helping to regulate those channels, like sodium channels or neurotransmitter channeling, but it's not, I don't know, the B vitamins are a little tricky. You'll notice that the two major things that happen with all the B vitamins is that you develop these nervous system problems, so tingling and then eventually paralysis can happen. But the other thing that you notice, which you'll start to learn about in the next lecture, is this dermatitis that occurs. So a lot with B vitamin deficiencies, you get a lot of dermatitis specifically around the mouth and on the tongue. And then there's lots of pictures and stuff that I'll show you in the next lectures too, to kind of show you exactly what that looks like. But why does that happen? Just because you don't have enough vitamin B, like, is it tied in somehow to like the Krebs cycle? Why is this dermatitis happening? We don't know. It's been hard to link basically these deficiency symptoms to an exact mechanism in the body. So, just that's some of the questions I usually get at this point in the lecture. So just to tell you, we're still unsure. Another thing I wanted to go over, just as we're kind of finishing up here, people that are at risk for B vitamin deficiencies, there's kind of like a couple major groups here. One is the elderly. Elderly are actually at risk for multiple nutritional deficiencies. So why do you think that is? why would elderly be at higher risk than, middle age or younger people? So the answer to that is basically intake problems. It's harder for people to chew. You might have like dental problems as you get older. It's more difficult to absorb stuff. The body kind of shuts down on itself. Absorption isn't as efficient as before. Access to food becomes very difficult for some people. So, just being able to afford food or even just being able to go out and get it, there may be like mobility issues, that type of thing. So, a lot of different, taste goes down as well. A lot of different things affect the elderly's ability to kind of acquire food and also just eat healthy. Alcoholics have in it like problems with absorption as well. So remember, if it was all tied back to that hydrogen thiamine antiport system, so that was on the basolateral side of the enterocyte. You can go back to those slides just to refresh your memory if you'd like. And then also some alcoholics may be replacing food with alcohol, so intake can also be a problem. In AIDS patients that are not kind of actively being treated or that having issues with treatment may have decreased food or vitamin intake. And then the other major groups are basically people with gastrointestinal problems, so that have some type of GI cancer. Obviously, that could affect absorption. And then people with irritable bowel syndrome or any of the irritable bowel or any of those inflammatory bowel diseases, such as Crohn's disease or ulcerative colitis, they can develop problems with absorption just because, literally. I have Crohn's disease, so I kind of know a bit more about this. But you're almost like melting your intestine or your colon. So obviously, if the tissue is that destroyed, it can't absorb things as efficiently. Toxicity. So the TUL, interestingly, for this B vitamin and some others, has not been established. And interesting, yeah, you can also look at how they set the TUL by looking at those DRI books if you're interested. But the way that they do it, because you can't, ethically, you can't run a study where you want to like toxify someone. Where you're like, well, let's see how much thiamine they can take before they like have a seizure or something like that. You can't do that. So the way that a lot of this stuff is kind of assessed is basically by case studies. So it's people that decided to take really high doses of whatever vitamin themselves, and then they end up coming into the emergency room and saying like, okay, I took this and now I'm experiencing this. So most of this is just from case studies. So what they found that people taking really high amounts, so like 500 times what you're supposed to, so 500 milligrams per day for 1 month, there was no toxicity effect. And that's probably just because, those capsules were probably just not, the tablets were probably just not making it into the body. Or if they were, the body can, excrete it via urine very quickly. They have had cases, though, where people decided to kind of do an injection of 100 milligrams per day, and then that resulted in, I guess, one person that did that in convulsions and cardiac arrhythmias. So again, water-soluble vitamins are generally, for the most part, except for B6, which I'll teach you about, fairly safe. Your body can get rid of them. Unless you like kind of mainline it and like add it like right into your system, which obviously I would not do. So remember, water-soluble vitamins, it's basically just vitamin C and then the 8 B vitamins. And what are the two major functions of the B vitamins? So what's the one that we went over today? That's right, energy release or energy metabolism. So that means basically the main point of the B vitamins is to help the Krebs cycle and glycolysis to kind of keep on moving along. And then the other major one is formation of blood components. So that's folate and B12, and we'll talk about that a little later. Okay, so let's do a quick review. You can stop watching here if you don't find this helpful. So food sources of vitamin C. Citrus. What are the main functions of vitamin C? Just to jog your memory, what did we go over? There's the one that everyone knows before the class. It's an antioxidant. It can also, in rare occasions, act as a pro-oxidant. Then there is all those hydroxylation reactions. So that's basically helping collagen to be formed. And then lastly, all the supplements. So basically part 2 of the vitamin C lecture. So why do people supplement with vitamin C? What were some of the things we talked about? So colds, interestingly, they all start with C. So colds, cardiovascular disease, cancer, and cataracts. Doesn't seem to work for heart disease or cancer. May work for cataracts. Doesn't really work for colds either, but I guess you can leave that up to whatever you think. Deficiency is called what? Scurvy. Toxicity of vitamin C, diarrhea, and kidney stones. All right, so thiamine food sources. I know it's hard to remember all the little details, but just try to remember for the B vitamins, it's primarily meats and grains. So meats and grains. Function of thiamine. Again, it's so hard to remember, but it's energy release. So remember alpha ketoglutarate to succinyl CoA, pyruvate to acetyl CoA, and then it's also involved in nerve conduction. What's the deficiency name for thiamine? Beriberi. And what's the toxicity disease? That was a trick question. There is none. So basically, remember for thiamine, there's no TUL and there's no toxicity disease right now that's been established for it. All right. Well, thank you so much for listening. And and just to remind you that my TA will be teaching the riboflavin lecture, but I will see you for niacin, which happens right after that. Great. All right. Have a great rest of your day.